רגע, יש מספר טיסה זה מספרים, זה אותיות גם? LY 38. Select time 1. How do you mean line?
anyway, LI.
Okay. Then
This
חוזרת.
field is required and should contain validate date, time of arrival.
לא, למטה.
מי זה?
לא, למטה.
אז מה חסר פה?
מה כאן כתוב?
כאן חסר משהו. אוקיי. זה מה שאת מגיעה. Final destination airport, רומא, נכון?
לא, במילאנו.
מילאנו? מילאנו? מלפנזה? מלפנזה את נותנת?
אני אגיד לכם, אני לא יודעת. רגע, אני אבדוק.
מלפנזה את נותנת.
972.
יחד הפריע לך. למדתם היום? צריך עוד משהו?
אז טוב אחתם את כל סוג המגורים. Neza habonamo cosa là. Esclusivamente passiamo al stream. Diciamo ora. Anche i miei di calcolo e lo relationship. אז לא ממש נכנסתי להם שהם היו עושים את זה. Tengamos que hacer descansarem no setor, mas hali marcha e proteger o setor. Então, esse poder, nós vamos tentar salvar necessários também. Fazer táticas que não dá, na terra, não há, seleção ruim, tá? Durante a lei, a gente pagava, a gente não paga. E olha para cá. Talvez mais força, aquele que é mais será uma
Yeah.
כללית היא אמרה לי שמגיע לי עד 3 חודשים בסך הכל של ביטוח בחו"ל. בשנה וחצי. לא, אבל אני אומרת לפני הרגע. זה לא דבר. אז נקרא לזה שזה לי כל מיני כאילו הנחות. אמרה לי, רגע, יש לי היא חייבת, יש לי למשפט זמן, יש לי שנה וחצי. יש שם שורית. זה הבשר ממש טעים. כן. תתן את זה בעלי. כל כך דרך ההודעה, נוכל להתעלם. מהרח שלי, לא רואה. והיום ראית את העבודה איתי על לא, תראה לי. וגם אתה יודע מה אנחנו עושים? מה אתה? ההורים לבטן שלי, אני מוכרח אותם בערב. רק סוף ולפעמים המשמעות. מה, אם נגמר? חלי רזה? מה? לא נשמע לי יש מישהו כוח לפעד לשמוע לדבר. אלילה מגיע נגיע בקרוב. מתי להרשה את הזום?
עכשיו יש לנו
מה זה הרצאה כזה לכולם?
שתי הרצאות שלפי אנשים בריטניה.
אתה גם לכם?
אני מאוד אוהב.
אז מה אתה אותם כאילו? תגיד, זה חוזר לכם הכנסים שאתה מארגן? לא, בעצם זה כבר לא מארגן. ומי מארגן את כנסי עיניים עכשיו? ואין כבר של העיניים שלכם? אני מתרגשת על זה. איזה כיף שאתה היית מארגן ברמות, בבית התאי שלנו. נגיבו? אבל אתה יכול לתאג אותי על כל הפוסט? לא, זה המצאתי בתמונות, אתה עושה על כל הפוסט. תעשי כאן רגע, בנקודות. לא, אני רוצה שתתאג, לא תתאג, edit post. עכשיו, בסוף המשפטים, תעשה השטג, נכון, אבל הסרטון זה לא מופיע בקיר. כל זה שתעשה, תכתוב השטג בסוף המשפט. כן, עכשיו תעשה למטה, תראה שמראה משהו, תעשה השטג. כן, ותראה בשביל שזה יופיע בקיר הסרטון גם. רק שתי אלה הופיעו לי, עכשיו הכל יופיע. קראתי באיטליה, באמת יש את כל העניין הזה של הארוחה, יש להם בארוחה, אין כאילו ראשונה עיקרית באמת אמרת אחרונות, יש מתאבנים, כן, כאילו פתיחים, שזה זיתים ובוטנים, ואז יש מנה, ואז יש לחם כל מיני דברים, ואחר כך יש מנה של פסטה או מרק, ואז עיקרית, ואז תינות, ואז את השתייה הזאת, כל לימונצ'לו. לא, הכירו את זה. יש לי טלפון? יש לך מתאמת שלעים בחו"ל?
כן.
באירופה איזה שקעים יש? מוזרים?
כן, יש פה כל מיני שקעים. זה הציפה.
רגע 2.
זה.
לא, לא מצטער.
זה אחד אחד. תוצאה 3. לא תשווה את הטעמים גם. אחד, שתיים, שלוש, אחד, שתיים, שלוש. 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 היי, צבי, מה נשמע? אתה על מיוט.
הלו, מה העניינים?
היי, מה נשמע? בסדר.
שומעים טוב?
כן, מי מצטרף אלינו?
גיא לא זמין, שלחתי לו הודעה, הוא לא כל כך עונה.
אוקיי.
שי ארגן לו את כל העניין, אני מקווה
אתה יצטרף גם?
אני חושב לא עכשיו בשבע, אלא הוובינר עצמו.
ב-9 אתם מתחילים, כן? בערך.
כן, אני מצטרף כבר ב8, אני אשמע אתכם, אבל
אוקיי, 100%.
כן,
תנסה לעשות share screen.
כן, בבקשה. share screen. דסקטופ. אוקיי, downloads. יש?
רואים את הדסקטופ שלך כאילו, אבל את המצגת אתה יכול לפתוח? שלך?
כן, שנייה. רואים את המצגת?
לא.
באמת? וואו.
רואים רק את הדסקטופ שלך.
מוזר, כי אני כן רואה את המצגת.
אתה רואה את המצגת?
כן? אני אעשה סטופ שייר ונעשה שוב.
היי דניס, מה נשמע?
מה קורה? אני נוסעת להדסה אחרי שאנחנו מסיימים פה.
מה קרה? את כוננית היום?
מה פתאום? אבל
למה
יש
את
לי...
נוסעת להדסה?
אני לא אצליח
עכשיו
להיות
רואים.
פה.
עכשיו רואים, יופי, עכשיו זה נראה מצוין.
כן, אז יש לי סרטון, תגידו לי אם הסרטון עובד, אם אתם רואים אותו.
כן.
כן.
כן, רואים את הסרטון. יופי. מעולה.
האמת שהדיבור שלי פחות מרבע שעה, ניסיתי להאריך, אבל לא לשעמם.
תספר בדיחות.
בזה אתה טוב.
תספר בדיחות. מה זה רבע שעה? תשים איזשהו סרטון מצחיק, שנזכור את ה...
תאמין לי שכולם רק ישמחו מזה. אם נשים איזה...
ברור מה. זה שעה קשה. שעה קשה.
לגמרי. לגמרי.
אתם בבית?
כן, את יכולה להעלות את השקופיות שאת הכנת על המרצים?
אוקיי, שנייה.
אתה אומר שגיא בן צימון, אבל בעניינים הוא הגיע?
מה?
אני אשלח לו עכשיו הודעה.
רק שנייה, אני צריכה שניונת.
בסדר.
אני צריכה... אני סוגרת את כל מה שפתוח במחשב שלי, כדי שאני יכולה להתרכז. שנייה.
את שומעת אותנו טוב?
אני שומעת אתכם טוב, אתם שומעים אותי טוב?
כן.
אבל אני נוסעת להדסה, אני מקווה שהווי-פיי שם בסדר.
למה את נוסעת להדסה?
כי בבית אני לא אקבל שקט, אז...
תשימי אוזניות, אז קודם כל, נעלי את עצמך בחדר.
מה? אני בתוך החדר.
או שתנעלי את הילדים בשירותים.
הקטע זה שאני מפחדת שהם יפתחו את הדלת פה ותיכנסו ואתה יודע. כי כרגע הם אוכלים, אבל אז אני הולכת להדסה.
אז תשימי להם משהו באוכל שירגעו.
הנה הוא כותב לי שכן.
שנייה, מה עשיתי פה?
כן? אז תגיד לו שיחבר אלינו.
כן, אני אומר לו עכשיו.
מי?
גיא בן צימון, המרצה השני באוקולופלסטיקה.
אוקיי, אני אעשה share screen שלי, בואו נראה אם...
נראה לי שעופרה לא שלחה לו קישור לפאנליסט.
יופי, רואים את זה יפה. תשימי את זה על סלייד שואו.
אתם רואים את זה?
רואים את זה מעולה. זה מאוד מאוד יפה.
ואז זה הסלייד שני.
יופי, מצוין. אז אני אגיד כמה מילים, איזה דקה שתיים פתיחה, איך אני אעביר את המסך אלייך. קודם אני אשים שקופית, תצאי רגע מהמסך שלך.
שנייה, סטופ שיירינג.
אז אני אעשה, אני מתחיל ככה. זה המסך שלי. רואים?
כן.
ואני אגיד איזה משפט או שניים, אחר כך אני אציג אותך, אני אגיד שאת עשית פלושיפ במורפילד, להגיד מתי או ש...
לא צריך להגיד מתי.
אוקיי, ואז אני אגיד לך, ואני אעביר את זה אלייך, ואז אני אעשה סטופ שייר, ואת תכניסי את השקופית של סייג'ד, ותציגי אותו, ואחר כך הוא ייכנס. אחר כך הוא מצטרף אלינו עכשיו?
אני שולח לו קישור, אבל כנראה שעופרה לא שלחה לו קישור של, אתה יודע.
אז תשלח לו את הקישור שעופרה שלחה לך.
אין בעיה.
כן? זה... רגע. אז עופרה לא שלחה להם את הקישור?
רגע, ניכנס אולי להגדרות של ה...
כי הם צריכים לקבל את האישור באימייל, נכון? באימייל...
כן. תשאל את עופרה אם היא הכניסה את גיא בן צימון. אני לא יודע, אולי אני הכנסתי אותו? אני חושב שאני הכנסתי אותו.
תגיד, אבי, אתה עושה share screen לכל פאנליסט ופאנליסט, או איך זה יעבוד?
אני עושה share screen לשקופית הראשונה, אחר כך דניס עושה share, כל פאנליסט עושה לעצמו share screen.
הבנתי. בסדר.
כי ברגע שהוא מוגדר כפאנליסט, אבל השאלה האם זה מוגדר, זה אני לא יודע.
מה קרה? Hi, Sash, how are you?
I'm well, you?
Hey, hi.
I'm fine, thank you for joining us 1 hour
Ahead of time.
We just wanted to see if, yes, I'm sorry to ask you this, but we just
That's
wanted to see if everything is working fine.
It's
How
fine.
are you doing?
I'm very well. How are you? How's work?
I'm fine, thank you. It's busy, but it's good.
Good, that's good.
Hey, Guy, hi.
Good.
Hi, Guy.
So this is Avi Solomon. This is
Hi, pleased to meet you.
Hi.
and this is Tzvi Gur, who is an oculoplastic surgeon, and this is
Guy Ben Simon.
Yes, because we have the first section it will be cornea, and the second session will be oculoplastics. Yeah. Saj, do you want to share your screen to see if it's working?
Yeah.
Okay.
How's that? It's good.
Right,
Oh,
yeah.
that's great.
That's very good.
Perfect. Yeah.
Okay.
Thank
So
you so
Denise,
much.
just share your slide on Saj, so you see if everything is correct in the introduction
Yes,
of your
I'm going
bio.
to share my screen. Yes. Is it a good picture of you?
It's a picture. I mean, there's nothing you can do, can you? It's it's the way I was made.
Yes. So, Saj, can you have a look if it's everything's correct in your
It's
bio?
perfect.
It says here that you are a clinical lecturer, but now I see that you are associate professor, right?
Yes. Oh, yes.
Okay.
True. But
Can you correct that?
Here I put I checked in the website of Morpheus. It's associate professor UCL.
Yeah, correct.
And
I used to be at University of Liverpool, but I'm not there now. But I used to be senior lecturer there. That's correct.
So should I keep it or should I remove it? What do you prefer?
It's fine. It's fine.
Okay.
So should I leave it there like this?
It saves a bit of work. Just leave it.
Okay. Perfect.
Okay, excellent. So everything works well. We just hope that Dan Gore finishes his surgeries on time, so he can join us also.
I hope for it. Yeah.
And is Dan joining or?
Yeah, he should.
Yeah, he should. Yes.
He gives the second lecture right after you.
He is. Yeah.
So after Denise will introduce you, you will share your screen, and then after you finish your lecture, we will have some discussion. We will ask some questions, and maybe the audience will have some questions in the chat area. And after we finish the discussion of your part, then we will Denise will introduce Daniel Gore, and then he will give his talk and so on. And once he finishes, here's Daniel.
Yeah.
Wow.
Hi. He looks busy.
Yeah. Did you finish cutting people, Daniel?
Hi, Dan. Can you hear us?
I think he's on Moorfield's Wi-Fi, so it might take a little while.
Okay.
It's like being on the moon.
Yeah, you fluctuate there. Yeah, hi.
Yeah. We can. Okay.
Hi, Guy.
Hi.
Do you want to check if you can share your screen? Because I checked Inspire. All right.
אוקיי, יופי. תעבור לפרזנטיישן מוד. יופי. מעולה. יש לך סרטונים שם, גיא? יופי.
It works. Great.
יופי, מצוין.
Right.
אוקיי,
Um,
מעולה. אז יופי, גיא, רואים יפה מאוד את המצגת שלך. אוקיי,
yeah.
טוב.
אוקיי.
Dan, can you hear me?
You are on mute.
You are on mute.
You're on mute. You have to...
Right, can you hear me now?
Yeah.
Okay, perfect. So look, I haven't got my laptop here, but I'm sure I can dial in. At least the link's working, so it should all work well. I can just screen share as normal, yeah?
Yeah, sure. So
Sure.
Saj will give the first talk,
Yep.
which will be followed by a discussion. And then you will give the second talk, and Denise will introduce you with a slide. And then you will
Perfect.
give your talk, and then we will have a discussion. Okay,
And,
great. So,
how many minutes do you want the talk?
15 minutes at least.
Okay.
15 to 20. Something
Fine.
like that. You feel free, but whatever it takes you,
Yep.
There's no limits here.
Okay, well, looking
Okay.
forward to it.
You finish your
Okay.
surgeries.
One more case, so
Okay.
fear not, I'll be there.
So I hope
Okay.
it's going to be
Thank
a
you so
smooth
much.
case.
Yeah, exactly.
Okay.
Okay, I'll
Okay,
see
so
you
we'll
soon.
meet again at 8 o'clock, okay?
Okay.
Yeah.
6 o'clock p.m.
Yep.
In UK.
See you soon.
Time.
Okay. Thank you so
Okay.
much. Thank
Bye.
you. See you
So
soon.
it's
Bye-bye.
it's 1 hour from now, okay? Okay. Thank you very much
Yeah.
for joining us, and we'll see you again in
Bye.
1 hour. Bye-bye.
See you soon. Bye-bye.
Thank you. Bye.
Bye. Okay, Denise, אז... טוב.
Sajid Ahmed, from whom I learned so much at my fellowship time at Morpheus. Mr. Sajid Ahmed is a PhD in stem cell biology. He performed a cornea fellowship with Professor Stephen Kay at St. Paul's Eye Unit at Liverpool, and a second cornea fellowship with Professor Dart at Morpheus Eye Hospital. He's an honorary associate professor at the Institute of Ophthalmology in UCL, University College of London, and an honorary senior clinical lecturer at the Department of Eye and Vision Science at University of Liverpool, a current consultant ophthalmic surgeon at Morpheus Eye Hospital, and one of the leading names in ocular surface research around the world. So it's a pleasure to introduce you, and thank you so much for joining us today. And he will be talking today. He will give a presentation on update on treatment of cicatricial conjunctival disease. Thank you very much.
Thank you very much, Denise, for the kind introduction, and to Avi for inviting me to the webinar this evening. I'm just going to share my slides, and we will start. So good evening, everyone. So I'm going to talk about the treatment options for very rare disease, which we occasionally see, and I have a clinic for it, so I see a lot of it, but for mucous membrane pemphigoid, which was one of the cicatrizing disorders of the conjunctiva. So if you recall back from when we were training, mucous membrane pemphigoid is a very rare entity. It's an autoimmune disease, and so it's systemically driven rather than local to the eye itself. And the target of the immune disease process is are the adhesion molecules in the basement membrane complex of all mucosa. So we see it in the eye, but actually it also affects the mouth, the larynx, the pharynx, can affect breathing and swallowing. So in certain patients, if it's not controlled, it can be critical. And it also has, in some patients, affects the urogenital system. On the whole, the incidence varies, but I would say it's about 1 in a million, and that's quite a conservative estimate. Usually, I mean, in the UK, we see, in our clinic, we have about over 300. So the incidence is probably more than that, but we say 1 in a million is a reasonable estimate. And when we look at the disease, the two components of the disease are an inflammatory process, so the conjunctiva is red, and a scarring process, which affects the fornices and the plica. And you'll see some pictures in a moment that highlight this. The pathophysiology of the disease is that it's driven by an antibody production to the basement membrane complex. So there is an acute inflammatory process that involves B cells and antibody production. However, in some patients, this becomes much more chronic beyond a period of time, and they then get what we call T cell dysregulation. So although the disease originally begins as a B cell response, the T cells and the rest of the immune system also becomes dysregulated as far as the mucosal membranes occur. And the inflammation itself, apart from it causing redness and pain, and its main effect is that it activates the conjunctival fibroblasts, and you get a disease process that involves significant scarring. And that's why we see the symblephron and the ankyloblephron, which are associated with the disease, that then result in the complications such as cicatricial entropy. These are some pictures. So you can see at the top, there's a very red eye, and that's often what patients will initially get, is just simple conjunctival injection. In some patients, you will see this conjunctival ulceration if you look carefully, and this is rare, but you can see it early on in the disease process. In severe inflammation, you also get limbitis. So you see this picture in the bottom left-hand corner. You can see the limbus has this white infiltrated appearance, and you can see this sort of stringy discharge. And actually, this isn't mucus. This is actually collagen degrading. So this is why it appears long and stringy, just like for example the vitreous would be. In severe disease, you also get the production of metalloproteinases from the inflammatory process, and you get epithelial defects, persistent epithelial defects, and corneal melting. And this is why it's a significantly important disease to diagnose and then subsequently treat, because the complications are significant. This is the scarring. These are the scarring aspects, and you can see here in the top left-hand corner, flattened plica, which actually everyone says is an early sign of the disease, but is sometimes very subjective and difficult to recognize. And often in severe disease, you can see the plica is completely obliterated. If you avert the top lid, you'll see an area of subtarsal fibrosis here. This is generalized forniceal shortening with some subtarsal fibrosis. And then you can see the obvious things, which are the symblephrons and the ankyloblephrons, which is when often the penny drops that this is a cicatricial disease rather than a simple conjunctivitis. And then the effect is, apart from persistent defects and the risk of infection and melting, and compromise to the globe, the other effects are you get cicatricial entropion and eventual keratinization of the ocular surface, which then limits the management strategies that you have available to the patient for them to see again. So pemphigoid is a rare but blinding disease. So it's important to recognize it early, because that's when input has its most effect. These are the other causes of conjunctival scarring, which you should also recognize. So you have, apart from mucous membrane pemphigoid, especially if it's unilateral disease, consider ocular surface neoplasia as being a differential here. And then the others are rare causes that we see, but we have enough of them to see some. So sarcoidosis, a rare cause of conjunctival scarring. Adenoviral disease, when it's aggressive with pseudomembrane formation. Severe atopic keratoconjunctivitis. Some patients get fornix involvement. Patients with Stevens-Johnson will also get it. I occasionally get once or twice a month patients with chronic glaucoma that are on topical medication that also get a cicatricial process. And then rosacea. Rosacea often causes this as well. So these are rare entities. The top of your list should be neoplasia and mucous membrane pemphigoid, which you shouldn't miss. And I'll show you how we can avoid that in a moment. So the main diagnostic tests that you have available are immunofluorescent tests. And these involve taking initially conjunctival biopsies. And I take one from each eye. And I also take an oral mucosal biopsy and send them off, because the more biopsies you have, the higher pickup rate you have for the disease. And the important thing to notice is that we're doing immunofluorescence. It's sent off, the biopsies are sent off in special medium called Michel's medium. We also put a separate biopsy from each eye into formalin to look for neoplasia as well. So one biopsy from each eye, one goes in Michel's medium, one goes in formalin. And then in addition to that, we take a blood sample. So we do serology for circulating antibodies. Looking for what they do is that you can do an ELISA, but often this is a test called indirect immunofluorescence. And what they do is they take split skin, so they take normal skin, split it, and it's often pig split skin, and you expose the basement membrane, and then you use a patient's antibodies from the serum. You use a patient's serum basically to do an indirect immunofluorescence. And if there are circulating antibodies, you'll get positive exposure and positive fluorescence. And the important thing to do is that in direct and indirect immunofluorescence, both of these tests can be negative. So a negative test doesn't rule out pemphigoid completely, and you can diagnose it on your clinical impression alone. A biopsy, however, helps, especially if you're putting them on potent immune suppressives. Now, when I see a patient with pemphigoid, these are the four things that I look for in this order. How inflamed are they? So how active is the immune process? Because inflammation is a thing that we can control. The scarring, the only thing that we can do with scarring is do surgery. So you have to document how much inflammation there is and manage it appropriately. And the best place to look for inflammation is you elevate the top lid and you look at the superior conjunctiva and see if it's inflamed. The other parts of the conjunctiva, the temporal and nasal, they're exposed to the environment. The lower ones, you often get lashes that then irritate that. So the lower parts of the conjunctiva are not that helpful, whereas the top one, because it's covered by the top lid, can give you a very good, unbiased opinion on how inflamed the surface is. And then you look for things like toxicity. So the patients will have uncomfortable eyes. They will use a lot of drops for comfort, as well as the medication that you give them, and they can get toxicity from preservatives. So it's important these patients get preservative-free drops if possible. And then in these patients, they have an altered flora on the surface, so their biome is abnormal. So always have a very high suspicion of infection, especially if they get epithelial defects. Have a very low threshold for putting them on topical antibiotics. The other thing to note here is that often these patients, because it's a systemic autoimmune disease, they will be on immune suppressives. And if a patient's immune suppressed, then they won't mount a normal infective response as far as keratitis goes. So you won't see white infiltrate. You'll often just see an epithelial defect, and eventually they'll start to melt. And that can be the first sign that they have infection. So have a very low threshold for taking swabs and PCRs for infection, and then treating it subsequently. And then you treat any other surface disease they get. So they often get distichiasis, where the lashes grow out from the meibomian glands, and you need to pull them out. So they repeatedly come to clinic and have access in your clinic for them to have epilation done, because otherwise those are going to rub on the ocular surface and cause more inflammation and more scarring. Because the tarsal aspect of the conjunctiva is often scarred, they also get scarred and cicatricial looking meibomian glands. So when we do lipid view on them, you will see very undulated and scarred meibomian glands. So they get significant blepharitis that you also have to control. They can get persistent defects and surface disease, and for that you have a low threshold for treating dry eye disease, and you have a low threshold for starting them on serum drops. And if all of this is not looked at, the eventual outcome is that the patient gets chronic dry eye and keratinization and surface failure, and then they get corneal blindness. And then the only thing that they can really have is an odontokeratoprosthesis. So when we now go on to management of the disease, topical management comes first, and topical management in pemphigoid is limited. And you can't give them copious amounts of topical steroid for long periods of time, because that won't control the disease. The disease has to be controlled with systemic immune suppressives. However, you can use topical steroids for very short courses when they do get inflammation after a lash growing in, or after initial surgery for their lids. You treat them with copious lubricants, and Schirmer's can often be a very early sign when it's low that they have scarring of their lacrimal ductules. So treat dry eye, and there's a step ladder that we use at Moorfields for dry eye management, and we follow that. You manage the blepharitis. We use oral doxycycline as a low threshold for this. Doxycycline not only for the blepharitis, but because doxycycline is a chelating agent, it prevents proteases from acting. So it can be very good as a wound healing role on the surface of the eye. So now we go on to the mainstay of management in pemphigoid, which is systemic. And because it's systemic management and we're not used to it, we feel anxious about managing these patients. The most important thing to do is that if you see a symblepharon, you are obliged to investigate why the patient might have it. So biopsies, unless there's another cause, another obvious cause in their history, you have to do the biopsies, and you have to have a very low threshold for considering pemphigoid. And because we don't use these immune suppressives in ophthalmology unless it's uveitis, we feel quite uncomfortable in managing them. And if you find it's not your area of expertise, refer them on, because these patients will progress rapidly, very rapidly, some of them. So in mild disease, so this is where the eye's mildly red, and they have mild cicatricial disease. So there's not much scarring, there's not much symblepharon. You can give them dapsone either 50 milligrams twice a day or 100 milligrams once a day. And if you're going to start them on dapsone, dapsone's main side effect is that it causes an anemia. And if they're negative in an enzyme called G6PD, or glucose 6-phosphate dehydrogenase, then you will, if they're low in that, then they will go into hemolytic crisis. It's important, if you're going to start them on dapsone, that you test their G6PD levels prior to starting it. Now, if they don't tolerate dapsone, or they have G6PD deficiency, then you can use sulfapyridine or sulfasalazine. However, if the disease is significant, so they've got significant inflammation, they've got significant symblepharon shortening, and you're really worried about their cornea, then you'll have to use oral or systemic steroids in the first instance. So we use 1 milligram per kilogram per day, and you tail it down by 5 milligrams every 5 days. The British Rheumatology guidelines state that you can use oral steroids for about 3 months without giving them bone protectants. But if they've got osteoporosis or if you're using them longer than that, then you're obliged to do bone scans and start them on calcium and atidronates. So steroids, the important thing to know here is if you use less than 40 milligrams of steroids, it's anti-inflammatory. Higher than 40 milligrams is immune suppressive. So you have to use it at a level that's higher than 40 milligrams. And steroids are the only thing early on in the disease that can really reduce the inflammation rapidly. In conjunction with starting the steroids, you start them on a longer-term immune suppressive. So this is something like mycophenolate, which is used at 1 gram twice a day. Very safe drug to use as long as you monitor the patients. Azathioprine can also be used. We usually use 15 milligrams 3 times a day. The main problem with azathioprine is you have to watch their liver tests very carefully. In very severe disease, you have to consider cyclophosphamide, and we use oral cyclophosphamide, especially if they've got limbitis and you're worried about them going into surface failure very rapidly. If all of those don't work, the thing to look for in cyclophosphamide, by the way, is make sure you do a urine dip regularly, because you can induce bladder cancer when used more than 25 grams in the patient's lifespan. For resistant disease, you have to consider then rituximab and other biologics. And I'll go into briefly what rituximab is. So rituximab is an antibody to CD20, which is expressed by B cells. So pemphigoid is a B cell initiated disease, so we target them. It makes sense. And rituximab was originally used for the treatment of B cell lymphoma, but it's now subsequently used for rheumatoid arthritis and also pemphigoid. And its US patents actually expired, so it used to be very expensive, and there are cheaper alternatives now available. And if a patient has blindness in one eye, or they have progressive inflammation that doesn't respond to all those other immune suppressives, or if they've got corneal involvement in both eyes and you're really worried, or if you've got a patient who can't take regular medication, they can't swallow them, then consider rituximab. It's very easy to use. It's 1 gram given 2 weeks apart, and then that's it for 3 to 4 months. And the patient doesn't really need blood monitoring apart from a month, which then shows that there's B cell depletion. And you repeat the course about 2 to 3 times a year maximum. Now remember that even if you do treat the patients, they will still get some scarring occurring beyond that, because scarring takes a while to shut off after the inflammation dies down. But if you don't treat them, progression occurs in the majority of patients. So you have to consider treating them with systemic immune suppression in this disease process early on. And if you've got appropriate monitoring of their bloods, then the patient's in safe hands. So there's no reason they shouldn't be given it. Thank you very much for listening to my talk, and I'll be happy to answer any questions if we've got time.
Yes, thank you very much, Saj, for this great talk. And we as ophthalmologists are reluctant to treat patients with systemic medications. We usually don't have a lot of experience with them. And you mentioned the shared care.
Yes.
And can you elaborate a little bit more about your experience with cooperation with rheumatologists or oncologists or physicians that know how to treat these medications and also to take care of the adverse events if they happen?
So your best friends when managing pemphigoid are actually your oral medicine colleagues, because often these patients have oral disease, or your dermatologists, because they're used to managing immunobullous diseases. The other group of colleagues that you can rely on, because they do a lot of immune suppression, is rheumatology. However, from experience, rheumatologists will, unless you've got a really good friend who's a rheumatologist and you have patients with Sjögren's who you co-share, often they're very reluctant to manage something that's very non-rheumatological. So, treating something where there's eye involvement is not, unless it's dry or Sjögren's, is not really their area of expertise. So they will then not, some of them won't be keen. However, if you've got colleagues, then, especially if they've got disease in another part of the body, so if they've got oral disease anyway, your oral medicine colleague, you will be able to discuss immune suppression and then, consider dermatology. So dermatologists now do a lot of immune suppression with a lot of the new biologics that are available for eczema, for example. So they will be used to it. And often dermatologists are more amenable to this. If I'm really stuck, I will arrange an MDT. So I will get everyone involved, from their general physician to their oral medicine person, dermatology. I will get them on a Zoom call, on a Teams call, and we will discuss the patient, because for me, not managing the patients and leaving them for months is not an option, because some of them rapidly decline. I have a patient at the moment who got referred in. We haven't seen him for about 3 months, and he's actually developed very rapid disease in both eyes. And I'm really worried about him having problems with his corneas in both eyes.
You don't have one specific authority in your service that you can consult with. You have different guys.
We do it ourselves. So Denise will tell you, we have no option. Moorfields is a standalone eye hospital, so we have very little access to other specialists in other disease types. So over time, we've learned to manage these patients ourselves. So I will routinely do immune suppression using all of the drugs that we discussed.
Okay, Denise, you have
and that makes it easy, right? Because I can manage the disease depending upon how bad I see them. So I see their eyes are bad, and I give them the treatment they need.
So in Moorfields, you have a very good pharmaceutics, right? That help to manage those patients. They are always on track of the blood work, and they communicating with the GPs. So it's a it's a system that really works. And the patients are always on track. I remember in the times of Corona, when patients couldn't come, and then the team was always on and checking on the patients and the immunosuppression and the blood tests. And it was very interesting to see. Saj, I have a question for you.
Yeah.
When we have those patients, they are usually they have steroids on top of everything, and they develop cataracts, and we usually are deciding when is the best time to operate them, to remove the cataracts before the cornea is scarred, but at the same time, we don't want to reactivate the disease. So my question for you is, how much time do you take, like a disease in remission, to operate them? And if you have a protocol of using some local or systemic immunosuppression perioperatively?
So I wish I had more time. I'd shown you my videos on cataract surgery and pemphigoid. They basically give me sleepless nights before, because there is no option. You can't drop a nucleus, you can't get vitreous, because you then have VR surgeons going into the conjunctiva, and these eyes go blind if they have a complication. So you have very little option as to what you can do. So if you've got a patient who has got pemphigoid, you control them as much as you can. The important thing is, don't leave their cataract until it's really bad, because they're awful to remove. And the reason I say that these are awful to do is because, one, you can't put in a speculum, you have to use lid sutures. You might sometimes have to do a canthotomy, because their canthuses are all fused together. You're often doing the surgery in a pool, in a swimming pool, because the water basically pools. Everything's scarred, so it sits there, and you need a very good assistant, often my fellow, who will mop up the fluid. And so don't leave them too long, and do them when they're obviously not mild, but when they're starting to get some cataract. Have a very low threshold for doing it. And then if you try and avoid manipulating the conjunctiva as much as possible, so no forceps touching the conj for traction, and if you are really worried that you're going to activate them, you can give them 20 milligrams of oral prednisolone for 2 weeks with 20 milligrams of omeprazole to cover their stomach, and often that's enough. And normally, as you know, we'll see cataract. You'll do a cataract, and the routine cataract, you might not see them for a few weeks. For pemphigoid cataracts, I always see them the day afterwards, and I see them a week afterwards, because if they're going to activate, they will activate usually by 1 week. And if they've got any complications like an epithelial defect or anything, you will spot it at day 1 and manage it.
So probably you would like to operate them as early as possible, even
Yes.
the stage of only seeing blepharon, and not wait until the cornea gets vascularization and so on.
Yeah, yeah, and you also do that. You can only really do you have to give them a peribulbar, and a good peribulbar, and you have to give them anesthetic into the lids for the lid sutures. The important thing is don't inject the lids, because otherwise everything will be swollen and you won't be able to get at the eye. I've done that before. I've made that mistake very early on before. So these cases, you have to. They're not a, however long you have for a cataract. They're not a 7-minute or a 20-minute cataract. They are 45 minutes, but they could be an hour and a half. So you have to set time aside in your theatre list for that.
Yes.
Do you wait for a remission for a certain period, like at least 6 months or more, like or as long as they are stable, do you operate them?
Correct. As long as they've got nice white eyes, you go ahead.
Okay.
Yeah.
Okay. We have here a question from the audience. Professor Kaiserman asks, can we use autologous serum drops in such cases, or do we worry about antibodies?
Very good question. So in the UK, what we did, especially during COVID, was we went on to allogeneic serum. So in the UK, we have something called the National Blood Bank. So every blood product or tissue goes off to that bank, and it gets stored there and analyzed. And this is partly because we had the issue of CJD within the UK. So because of that, all blood products are centralized. So they make our serum. And we decided we were going to use allogeneic serum from donor blood, which has been screened, rather than using autologous. So if you've got patients with Stevens-Johnson or pemphigoid or graft-versus-host disease, actually, you're taking their own serum and giving them pro-inflammatory factors back into their eye. So we use allogeneic serum more and more here now.
Yeah, another question about rituximab. We don't have a lot of experience here. In your practice, what is the percentage of patients who need eventually rituximab?
Very low. So we have the National Health Service has given a quota nationally, so we can give 30 patients with pemphigoid rituximab a year, and I usually have about one to two every 6 months. So it's about 4 a year, maybe. But I see a lot of pemphigoid, so it's rare, but I will have a very small number of patients on rituximab.
And another question.
We have a question from Lana, and she's asking if can we use a finger prick in those cases regarding
Yeah, so the other thing that we did in the UK was, because we had, especially during COVID, we had a problem with getting serum drops. We used whole blood, so we got the patients to do diabetic lancers to prick their fingers and use that in the eye, because it contains even more growth factors. I would actually avoid it. Shall I tell you why? Because these patients are immune suppressed, and they put loads of other stuff in the eye, and they're wiping their eye because it's uncomfortable, and you worry that they'll put in blood from a finger and then get an infection. So in these patients, I would probably not, but for Sjögren's or some other stuff where there's a lower risk, I probably would consider it.
We also have here a question from Dr. Tzvi Gur, who is an oculoplastic surgeon, and he will speak later on. When is it safe to operate on the lids? I assume it's never safe to operate them at all.
So I work very closely with David Verity, who some of you might know, who's one of our oculoplastic surgeons, and he is very good at doing fornix reconstruction. So he's my go-to oculoplastic surgeon when it comes to this. And what we do is we co-manage the patient. So if you are going to touch their conjunctiva, we will give them 40 milligrams of prednisolone post-operatively, and we will reduce it afterwards. And if you manage the patients, you give them immune suppression beforehand and you give them immune suppression afterwards, they do really well. I mean, David's results are fantastic. So I think the thing with fornix reconstruction and entropion repair and such diseases is it has to be done by someone who does lots of it.
Right. Okay, great. Thank you very much,
welcome.
Saj, for this great talk and for the discussion. And we have to move on. So Denise, please introduce to us the second speaker. Denise, you are on mute, so please open your... Okay.
Just a moment, I think okay. So first of all, thank you very much, Saj. It was a great talk. And now it's a pleasure to introduce the next speaker, Mr. Daniel Gore, from whom I also learned so much at Morpheus at my time there. And it's a pleasure. Thank you so much for accepting our invitation. Mr. Gore, he had a fellowship in cornea and external diseases at Morpheus Eye Hospital. He has a doctoral thesis in new interventions for keratoconus. He's an honorary clinical lecturer at the Institute of Ophthalmology at UCL and a consultant ophthalmic surgeon at Morpheus Eye Hospital, and he's a director of refractive surgery at Morpheus with extensive knowledge in keratoconus and refractive surgery. And thank you so much for joining us today. And he's giving a lecture on combined protocol of cross-linking and surface ablation for keratoconus.
Great. Many thanks, Denise, for that introduction. Look, it's a real pleasure to talk to the group. Next time, you must send me an invitation to come and visit.
Definitely.
It's my one and only visit to Israel in 1986, so it's probably about time that I came again. So let me just find my screen to share. Let's have a look. Great. Denise, can you just confirm you can see that?
Yes, we can. Thank you.
Okay, great. So, so my brief is a discussion on combining excimer laser with cross-linking. And I'm principally going to be talking about these two techniques. So surface treatments, trans-PDK and trans-PRK, both combined with cross-linking. Now, the reason I've put this slide here of a patient with advanced ectasia in a scleral lens is just to make the point that although as a surgeon, I'm talking to you this evening on surgical intervention, I'm a huge fan of contact lenses, and I'm lucky to work with some fantastic optometrists who in many cases can achieve the most remarkable results in someone who's otherwise functionally blind. There is a place for excimer laser, and it's typically where cases are not so advanced as the example I'm giving on the right. But I don't want you to take away that the message from this talk that that any keratoconic is amenable to excimer laser. It's just not the case at the moment. Now, traditionally, if you were to describe applying excimer laser to patients with keratoconus, you would have been criticized as being reckless. In other words, before the era of cross-linking, deliberately thinning the cornea, certainly in a younger patient, was a quick route to worsening their disease and ultimately ending up with more progressive ectasia. But obviously all of that has changed in the advent of cross-linking, and I'm not specifically talking about cross-linking this evening, but suffice to say that whatever type of epithelium off protocol that you're using, you can expect really very impressive rates of stabilization, at least sort of 90%. With a single treatment. Some of the younger children, they may need watching more closely. But cross-linking itself is not refractively neutral either. And while stability is the main desired outcome, many of these eyes will flatten. And initially that's a sought after response to the intervention, particularly if you're starting off with a very steep cornea. But don't forget one complication which is not talked about perhaps enough is that of long-term progressive flattening. And it's something that we've identified in our patients, and I'm sure if you look at your own data over long enough, you will also see patients who continue to flatten. The graph on the right here is just 3 eyes reported by Theo Seiler a few years ago, all with at least 10 years of follow-up and all continuing to flatten. And while it was desirable in this sort of stage, at some point that flattening becomes pathological and you shift them over into hyperopia. And in the same way that progressive steepening of the cornea is difficult to manage with changes in prescription and contact lens fitting, well, so too is progressive flattening. But this is also important in the context of combined cross-linking and excimer laser. And really, you only want one procedure to be changing the shape of the cornea. And you want your cross-linking to be as refractively neutral as possible. And so the cross-linking that we do here at Moorfields, with or without excimer laser, is as refractively neutral as I think you can get at the moment. It's not the original Dresden protocol, neither the parameters in terms of energy and power, and nor in terms of the device. The device itself is probably the greatest culprit in why many early cases of cross-linking show really quite marked longer-term flattening. And you probably yourselves originally started off using a device from IROC, which came in a sort of black briefcase, and you had to build it yourself each time you wanted to use it. And it had 3 overlapping diodes, which acted a bit like a Venn diagram, so that in the middle you had energy which was being sort of layered, or power being layered on top of each other. And so you had a central hotspot in the middle, meaning that the total energy delivered right in the center was far greater than the energy delivered in the periphery. And this is a heat map just recording energy with the original IROC device. So you had a hotspot, and no wonder therefore that you're overcooking the central cornea and that you're inducing therefore flattening or a more aggressive cross-linking response than you might wish for. Compare that to a more contemporary device, and the KXL from Avedro is the one that I've got most experience with. I don't have any financial disclosure related to Avedro, or indeed any other cross-linking device. I should have mentioned that at the start, apologies. But this has one key advantage, and that is that the energy delivered is homogeneous. In other words, across the 9mm diameter, you are delivering the same amount of power, and therefore over a few minutes or however long you're treating, you're equally delivering the same amount of energy across the tissue. And overall, those patients that we treat with just cross-linking, using this accelerated protocol, so again, this is not Dresden, this is 30 milliwatts, and for a significantly reduced time compared to Dresden. When you then map the changes in, when you map the keratometry changes over time, effectively we see flat lines, and I'll show you some slides of that later on. So the cross-linking itself is reasonably refractively neutral, and therefore you can have more faith that the changes you make with your excimer laser will be the ones that really matter. So if you're sort of embarking on combining excimer laser with cross-linking, it's quite useful just to start off doing some phototherapeutic keratectomy treatment, so a PTK. And I always do these as a trans ablation. In other words, don't take the epithelium off, ablate through the epithelium. If you're lucky to have a laser such as the Amaris that can do that, great. But even in some of the other platforms that don't specifically have a transepithelial profile, you can still program in a PTK, but just dial the numbers up and ablate through the epithelium. And these are the parameters that I would typically use, somewhere around 50 to 55 microns in the center, which on the Schwind has a standard epithelial profile, which increases the thickness of the ablation in the periphery. Now, why keep the epithelium on? Well, that all relates to what a fantastic masking agent the epithelium is. I've included a figure here from the Pentacam. So this is a Scheinflug image, and it's not nearly as high resolution as OCT, but since the Pentacam is by far and away the more widely used device, you can still use this in looking at individual sections to gauge whether you've got epithelial thickening, particularly over the cone. And because your epithelium will be, to an extent, sort of filling in the peaks and troughs, if you then ablate through that, you will end up with a smoother profile. If you mechanically debride the epithelium, you're exposing that more irregular profile. If you then apply PTK onto that, you're just going to have the same irregular profile, but imprinted 50 microns further down, or however far you want to take it. I'll just show you just another couple of images about the epithelial masking. So these are obviously with OCT. Now, this is a very gross example, and I'm not suggesting that this is amenable to laser, but just to show that in very advanced disease, the epithelium really does a fantastic job. You can see here the epithelium is more than half of the thickness at the corneal apex. The stroma has completely collapsed. And on another display from this particular machine, which is the MS39, you can measure the epithelium and you can see how thick it is over that central area. More relevant to the sort of refractive interventions for keratoconus are these more mild cases of the disease. So this is a typical stage 1 patient where you've got some posterior ectasia. The epithelium has thinned fractionally over the cone, but overall the profile is, at least on the front, is reasonably normal. And again, you can see some subtle thinning over the cone if you look at the other display here. So what sort of changes can you expect to see with trans-PTK and cross-linking? I've given you 2 examples. They are variable, and that variability probably is explained by the changes in epithelial thickness for a given standard epithelial ablation. But you can often regularize the cornea a little bit, and you get a little bit of flattening depending on how much epithelium you ablate, and how much, perhaps a little sliver of stroma underneath that. Sometimes with more inferior cones, you'll get this seesaw approach where the top half of the cornea steepens, the bottom half flattens, and overall you get a more regular profile. So in these images, just to clarify, the image on the left is post excimer laser and cross-linking. The image in the middle is pre, and the image on the right is the difference map. So those are 2 examples. And if you look at the literature, most groups have reported improvements in acuity of approximately 1 line in corrected distance vision. So the other technique, or at least a sort of a next iteration on from PTK, is a sort of more customized or bespoke approach, and that's using either topography guided or wavefront guided trans-PRK. And again, importantly, this is an ablation through the epithelium, because you'll still want to take advantage of how great a masking agent the epithelium is. This is one example, and I'll go through the details of how we program these in a moment. So this is a patient with relatively mild disease. I'm not pretending that this patient started off at count fingers and ended up at 2020. But this is a patient so this is logMAR acuity. So in the UK, this would be just about above the driving standard, but not much better than that. And this patient had progressive keratoconus and underwent ocular wavefront guided trans-PRK and cross-linking. And the specific aim of the excimer laser is just to treat the irregular astigmatism. So that's the higher order aberrations, which in keratoconus is almost exclusively coma. This is not to treat their sphere or their sill, lower order aberrations. And that way you can minimize the ablated tissue, because that's still going to be important. So here's what the cornea looks like afterwards. You can see they've still got astigmatism, but it's more regular. You can see the bow tie is more symmetrical. And the ablation map effectively shows you what the laser has done. Superiorly, the laser, the ablation map is a bit like a hyperopic ablation. So steepening this area, which has become pathologically flat. And inferiorly over the cone, the ablation is more like a myopic ablation. In other words, flattening the steepest part of the cornea. And the net result is that you shift the vertex back into the middle, and then you get this more regular shape. And all for fairly homeopathic tissue loss. We're talking here, just under 30. I'm sorry, I'm just keeping a watch on the time there, looking at my stop clock. Denise, you must tell me when I've got to stop. So how do we program these? So these are done on the Amaris laser. And you can either take a corneal wavefront, so a topography, or an ocular wavefront scan. And I'll tell you why ocular wavefront is better in a moment. But initially, if you were to ablate everything, the initial sums have come out far too high. So it's expecting to ablate 100 microns to treat all the lower and higher order aberrations. And clearly, no sane person would ever do that in a patient with keratoconus. But here, what you can do is selectively switch certain elements of the Zernica tree off. And the first thing to switch off is the lower order changes, which is the sphere and the sill. So we uncheck these 4 boxes, run the algorithm, and already your ablation then drops by 2/3 down to 33 microns, which is already becoming much more palatable. You can then go further into the higher order aberrations, and here you've got the Zernica tree of different aberrations, and there's coma, vertical coma, which I mentioned is by far and away the more important one here. And you can let the software do the hard work here. So rather than manually switching things on and off, which you can do, you can just press this minimize plus function down at the bottom there, and it will only then treat those aberrations which are greater than 2 standard deviations from the mean. In other words, ignoring the irrelevant stuff and just concentrating on treating the important aberrations. And again, we get a small reduction from 33 microns down to 30 microns. And then that's what you're left with as a final ablation map. So flattening over the inferior cornea, steepening over the superior cornea, and you can increase or decrease the optical zone or the total ablation zone as you wish. And if you haven't quite got far enough, and let's say you're only able to program an ablation out to 7 or 8 microns, if you wanted to cross-link further than that, you can just get a hockey stick and debride the epithelium so that you're cross-linking as much of the cornea as possible while limiting the refractive change to the visual axis area. So here's some examples, sort of before and after. The middle column is before the treatment. The column on the left is after the treatment, so PRK and cross-linking. and the column on the left is the difference map. This was the example I gave you before, and you can see exactly what the laser has done. It's flattened over the cornea, steepened superiorly to give us a more neutral post-surgical shape. Here's another example, again, an inferior cone, significant flattening superiorly, steepening over the part that was pathologically flat. You can see that the superior keratometry measurements are in the mid to high 30s, so definitely too flat. And although this doesn't look perfectly regular, you're starting to see a less extreme changes, particularly over the central pupil here, where the colors are more within the center as opposed to right up at the top here. Another example, again, the same pattern, flattening inferiorly, steepening superiorly. Here's a much more advanced case where it's still quite irregular, but you're starting to see all of a sudden that there is some sort of regular bow tie configuration to the astigmatism there. What's changed there is a significant degree of flattening over the cone, where the keratometry has changed certainly in your favor, or in the patient's favor, I should say. And one last example. So when we originally started doing these, they were done as part of a clinical study where we had two groups, one with cross-linking only and the other on the left here with combined PRK and cross-linking. And with cross-linking only, effectively, we don't see changes in their corrected acuity or uncorrected acuity, but certainly we see improvements. And in terms of corrected acuity, you can expect about 1.5 lines to 2 lines of improved vision with spectacles. You can see here what happens to the keratometry. On the right is just cross-linking only, and effectively no change, as you'd expect with this accelerated protocol using the KXL device. And you get an immediate degree of flattening from the laser, but then reassuringly, broadly speaking, not much in the way of changes post-operatively. So a small degree of flattening, but not much more. And that means hopefully that we're more refractively neutral than if we were using Dresden cross-linking. And the interesting thing is that even though we're not targeting the lower order changes, so sphere and sill, we typically get a reduction in the astigmatism by about half. So you can see the mean here changing from about 5.2 to 3.2. They also get a bit of a myopic shift, which is actually helpful in many of these patients, particularly with mild and moderate disease, where often they're hyperopic with significant degrees of astigmatism. So a small myopic shift of 1 or 2 diopters is not really a problem, so long as they get better vision with their new prescription and glasses. So there we are. There's a whistle-stop tour through trans-PRK and cross-linking, and if all else fails, you've always got your pinhole sunglasses as demonstrated there. Thank you very much.
Thank you very much for this excellent talk. And I was wondering if you have a longer follow-up period of 3 or 5 years. What happens in the long term for these patients? After all, keratoconus is a progressive disease.
So we're just getting ready to submit the 5-year data. And the most reassuring thing is that we're not seeing more failure. In other words, the underlying condition progressing again compared to just cross-linking. I think that's the biggest criticism or the biggest concern that certainly we had when we first started this, was that are we going to undermine the effectiveness of the cross-linking by being too clever with the laser? And there's longer term data actually from, so John Kanellopoulos has been doing his Athens protocol, which is a little bit different, but it's the same principle, with I think 7 or 8 year outcomes now. And we don't see any more treatment failure. So if it works initially, it seems to hold.
And thank you so much for your talk. It was an amazing talk, as always. I have a question for you. In the literature, we see lots of people who are doing different things, such as in keratoconus progression, in keratoconus under progression, or patient or surgeons doing after the keratoconus had stabilized and just treating the conus itself with its protocol. What are the inclusion and exclusion criteria in Morpheus? I mean, would you do in a patient that has a good vision with the spectacle corrected or contact lens corrected the functional vision of 6/12? Would you do or would you wait? What is your inclusion criteria in those cases?
Okay, so I guess the at the top of the list is progressive disease. In other words, I would feel very nervous about ablating someone's cornea which had stabilized, because eventually you're going to run into trouble by then destabilizing someone's keratoconus, and they won't thank you for that. The best candidates are those patients with stage 2 or stage 3 disease, and that's using the Krumak classification. So it's not suitable when the cornea is very advanced. Usually you need about 425 microns of cornea, including epithelium, because if you're going to ablate 30 or 35 microns of stroma, you still want to make sure that the residual bed is safe to crosslink. So I like to stay above 375 when doing the crosslinking part. Those patients who are very dependent on rigid gas permeable contact lenses, you can treat them so long as you can get good wavefront scans, but sometimes they're so irregular that you just can't get good either topography or wavefront scans. And you're then really unlikely to get a meaningful improvement in the vision. I posed one question earlier, which I didn't answer, but I said I would. The difference between programming the PRK with topography or programming the PRK with ocular wavefront. The reason why ocular wavefront is better is because you ablate less tissue. And that's because you are interpreting both the front of the cornea and the back of the cornea. And because the back of the cornea is negatively powered, if you program for the same eye, a topo-guided versus wavefront-guided, your topo-guided ablation will be deeper. And I always try to preserve as much tissue as possible. In most of these young patients, they've got nice big pupils, so it's usually not a problem. And I guess the final thing that I get nervous about is those patients with ocular surface disease. Obviously, there's many of these keratoconics are atopic, and a bit like the talk that Sajjad was giving just earlier, they need to be as well controlled as possible, because otherwise you risk running into delayed epithelialization. I mean, similar to just cross-linking on its own, but perhaps the implications are more when you're thinning the cornea deliberately with excimer laser.
Okay, so thank you very much, Dan, for this great talk and for the discussion, and thank you, Denise, for introducing the speakers from Moorfields Eye Institute. We learned a lot from you, and thank you for you and for Saj for joining us at this late hour. And now I will turn the flag on to our oculoplastic colleagues, Dr. Shai Ophir and Dr. Tzvi Gur, and you will continue on with this webinar. Thank you very much, Denise and Dan.
Thank you.
You're welcome.
And Denise and everyone, can you hear me well?
Yes.
Yes.
Yes, we can hear you.
Thank you. Okay, so thanks for the great first session on the cornea update, and welcome to the second sexy part of oculoplastics. We have two great lectures. The first by Professor Guy Ben-Simon, and the second by our own one and only Tzvi Gur. I'd like to introduce Professor Ben-Simon. You see him under the title Tzvi Gur Hill. So you'll see two Tzvi Gur, one is Ben-Simon and one is the true Tzvi. I think most of us, if not all of us, know Guy, head of oculoplastic in Sheba Medical Center, a great physician, a very talented, very skilled one, a great knower. And I must say that he's also a great friend. We go back a couple of years now, and I think he's my my go-to person whenever we have issues or dilemmas with oculoplastic cases here. He's always giving a hand and always happy to help in basically anything. Recently published a great book on orbital imaging, which we'll probably maybe hear him speaking about in the second lecture. And without further ado, I'll be happy for a Guy to start his lecture on total upper eyelid reconstruction.
Hi, thank you, Shai and Tzvi, for inviting me. So the first talk will be a short brief about the new therapy modalities and periocular BCC and squamous cell carcinoma, locally advanced. We'll start with a short case presentation about total upper eyelid reconstruction. This is an 81-year-old male. He's a former police officer. And prior to admission, he underwent most micrographic surgery for left temple basal cell carcinoma, which was reported to be completely excised. And I looked at the op note, and that's what was written at the end. He had local recurrence despite complete excision of the basal cell carcinoma. And during the last year, he underwent 10 surgeries. And eventually he underwent cutaneous flap, and there was no orbital involvement, at least in the medical record. This is a gentleman as he arrived to our clinic without any further ado. They just sent him with his lower eyelid. I don't know if you can notice, his lower eyelid is attached by a single stitch to the brow. There's no upper eyelid at all. This is a rotational flap from the scalp with the hair. They were planning to do laser hair removal from this flap, so it will look more sightly. If this suture would have broken, you would assume what would have happened to the cornea. Because the eye can live without the lower eyelid. You can remove the lower eyelid at home, nothing will happen to the eye, apart from lower punctal epithelial keratopathy, lower conjunctival irritation, or maybe scarring, but it will hardly affect vision. But if you remove the upper eyelid in total, the eye cannot survive for 1 day. So they just put one stitch. Luckily for him, they put one stitch and then sent him to our clinic. There's no easy way to reconstruct the upper eyelid. The most common technique used is Cutler beard, that you take full thickness flap from the lower eyelid, including skin, muscle, and conjunctiva and tarsus, and you pull through to the upper eyelid. Sometimes you use ear cartilage or nasal septal mucosa to the lower eyelid as a sandwich graft, but you don't have to use that. The main problem with the Cutler beard flap, it's relatively easy to perform and it looks nice. However, the patients cannot tolerate that. All of them use therapeutic contact lens. Without the therapeutic contact lens, there is severe ocular surface irritation with punctal epitheliopathy. But many people still use it because it's relatively easy to perform. So I consulted, as I do almost every other week or every month. There are many excellent oculoplastic surgeons in Israel, and I consulted my colleagues in Australia and the States. And actually not many could give me persuading support to how to reconstruct the upper eyelid. But Mr. McNabb is a very experienced surgeon from Australia. He's retired now, or stepped back a little bit. And he told me there's a great book by Mustarda, who is a general plastic surgeon, of doing total upper eyelid reconstruction by lower eyelid switch flap. And apparently I had that book because we had a medical library in the department, and the former department chair closed it down because he said there's no room for a library in these days where everything is web-based and you can Google everything and use the internet for everything. So I took all the oculoplastics books, and I have oculoplastics books from 1960, 1970, where everything was drawn by hand. And Mustarda, who wrote the book, actually described how to reconstruct the total upper eyelid, which almost looks like a science fiction, but actually it's doable. The steps are just to divide the lower eyelid and leave a small hinge, about 4 millimeters, to provide vascular supply. to do a Mostarda, a cheek flap, and then to rotate the lower eyelid to the upper eyelid, and the cheek to rotate to the lower eyelid, and put a nasal cartilage cartilage here for the lower eyelid support. And after 2 weeks, to divide the flap. And then it will get blood supply from the vicinity of the new upper eyelid. You can also reattach the levator muscle. So this is the first time I actually used that. And this is the operative picture for that police officer. As you can see here, there's no upper eyelid at all. This is the design of the flap. The design of the Mostarda flap, which is relatively easy to perform. There's nothing, just a skin and fat. It's not something complex. Obviously, it's done under general anesthesia, but it can be performed under local anesthesia. The last case that we did was under local. And then an ENT surgeon harvests a nasal mucosal graft. Actually, it's a composite graft. You take nasal cartilage and mucosa. And interestingly, the lower eyelid can be replaced by many materials, but we cannot put any other materials on the upper eyelid that the ocular surface will be okay with that, because anything we put on the upper eyelid, even if we take tarsus from the other side, the lower eyelid, it will not survive. But the lower eyelid can actually cope with almost everything. We do relaxing vertical incision, so there will be some flexibility to the new lower eyelid. This is the way the patient looked at the end of the surgery. This is the lower eyelid rotated 180 degrees to the upper eyelid. The Mostarda flap and the cartilage is inside, as we can see here. And this is the patient looked about maybe 1 month postoperatively, and I was very happy with the result. Obviously, there was no motility to the upper eyelid, but the cornea was well protected. There was mild, interestingly, very mild ocular surface irritation. He could see with the eye, and I plan to do ptosis on him at a later stage. There's no motility to the upper eyelid, even if that I reattach it to the levator muscle remnants. However, several months postoperatively, the patient has recurrence of his basal cell carcinoma. Obviously, it was not a basal cell, it was a basal squamous carcinoma, and there was perineural invasions. The general plastic surgeon at our hospital, besides operating him, they didn't do any imaging at a later stage. And I believe this was the case even when we operated on him. And he succumbed to the disease short afterwards. He was offered chemotherapy, radiation. There was no PD-1 inhibitors back then, and I'll just talk about the last paper that we submitted about PD-1 inhibitors, but back then we couldn't treat with this treatment. It was not accustomed, so he died short after. The second case is an 80-year-old female. She was a nurse, and she had an eyelid melanoma with fornical involvement. We did a sentinel lymph node biopsy by an ENT surgeon. It was negative. It's mandatory to do a sentinel lymph node biopsy for melanoma and sebaceous carcinomas. For other tumors, it's controversial. And this is a short video showing you how we performed the same surgery on that patient. And we operated that case, Dr. Landau and myself. This is a drawing from the original book of Mostarda. This is the design of the Mostarda flap of the lower eyelid, the switch flap. Intraoperative image. This is the nasal composite graft, mucoperichondrium graft. I did a relaxing incision, so there will be some motility to the eyelid, suture to the lower eyelid retractors. And then you just mobilize everything. You mobilize the cheek and you mobilize the lower eyelid. You rotate it 180 degrees, and then you firmly attach it to the medial canthal tendon on the lateral orbital rim. So there'll be good fixation points. This is the way we attach it to the lateral orbital rim. After you do the prior attachment, the surgery is relatively easy. There's a contact lens on during the surgery, so the cornea will not be dry. And sometimes we put Gelonet on that. And then you attach it to the remnant of the levator in conjunctiva. So you have to get some motility of the eyelid. Surgery takes about 3 to 4 hours as a whole. For melanoma, such in this case, we cannot do a frozen section paraffin examination intraoperatively. We have to do rapid paraffin because we cannot do frozen section on melanoma. So we operated on her, waited about 1 week for the results, and after 1 week, we did that surgery. And then we excised the flap, do adjustment. Obviously, this was not the last surgery we did on her. We did the reconstruction of the lower eyelid again and of the upper eyelid, and she's planned to do upper eyelid ptosis surgery. When you do the eyelid margin, you try to do mattress sutures for the new cornea, so the knots will not abrade the cornea. And again, firm reattachment to the lateral canthal area. Also, you have to secure the moustache flap so they will not get cicatricial ectropion of the lower eyelid. And then just simple knots throughout the flaps. You see, it looks really nice at the end of the surgery. Obviously, there will be a lot of edema, lymphedema after surgery for several months, and there will not be motility to the upper eyelid for the first few months. This is the way she looked at the end of the surgery. This is the way she looked 1 week after surgery. And then we did the vision of the flap and the local anesthesia, of course, and do reconstruction of the lower eyelid. This is the way she looked about 1 month post the second surgery. You see a lot of lymphedema, and this is again about 3 months post-operatively with a lot of lymphedema, but the eye is preserved. And she's planned to do TOSI surgery. Now she looks better. I have recent photographs and she looks better than that. So if we go about two topics I would like to discuss about most micrographic surgery, which is considered the gold standard in periocular BCC excision. But we published a paper with Yasur about patients who underwent most micrographic surgery, and all of them recurred in a very aggressive fashion. This is a lady after most micrographic surgery with severe recurrence, and that's before the area of the Vismo de Jib. And you can see excessive surgery with good reconstruction. And this is the patient I discussed about you, but that was a basosquamous. This is a patient with an interesting name. He has the same first name and surname. He underwent multiple surgeries. He cannot tolerate Vismo, and he has severe recurrence inside the orbit with frozen globe, but we could have preserved the eye with some vision. So for locally advanced periocular BCC in the past, but 2015, which is not long ago, exenteration was the treatment of choice. And this is a report by Dinesh Silva, who is one of the most distinguished oculoplastic surgeons in Australia and in the world. His wife is a dermatologist. So the risk factor for orbital invasion were male gender, advanced age, large tumor size, obviously, and medial canthal location, and aggressive histologic types as the infiltrative, sclerosing type, or basosquamous. Perineural invasion is very common with squamous cell carcinoma. So his conclusion was that orbital exenteration is the treatment of choice for BCC or squamous cell with orbital involvement. Actually, this was the most common cause of exenteration back then. And I published a similar paper in 2006. The first report was a case report by Alon Kana, was at our meeting about the Vismo de Jib or Arivage as eye-sparing adjuvant for orbital basal cell carcinoma with Vic Elner. That was in 2013, almost 10 years ago. And after which many papers by Rona Silkis from San Francisco with about 25% complete response and 25% or 35% partial response, actually good response to Vismo, and what saved the patient mutilating surgery as exenteration. And an additional paper about relatively high rate of complete response and partial response. Another paper by Det Sagiv and Bita Ismaili, he did fellowship training with her and MD Anderson. Again, about 60% complete response and about 40% partial response, with long follow-up with disease-free survival. In the past 2 years, we published several papers about the efficacy of Vismo in the treatment of locally advanced BCC. And we actually published the largest series. Maya Eiger published this paper about nearly 50% complete response and 50% partial response of the mean follow-up of almost 2 years. And there was low-grade adverse effect for Vismo. And a recent paper that we published from the 244 patients with locally advanced periocular BCC. These patients were taken from the Stevie trial. About 1/3 of them had adverse effect, and patients actually, the younger patients cannot tolerate the medication and they prefer doing a relatively big surgery than taking the medication. In this case, then you can stop the medication, give them on alternate days, alternate weeks, alternate months. There's no fixed regimen of how we should take the medication and for how long we should take it. But if patient had adverse effect, then you could stop the medication and reuse it afterwards. Again, 1/3 complete response and 40% partial response, which are good numbers. What we also found is that vismodegib improves the quality of life in patients with periocular locally advanced BCC. These also patients from the Stevie trial. And so this also improves quality of life because patients have severe motility problem and ocular surface irritation. And if we do surgery may be successful, but it is associated with very severe morbidity, especially when we're doing eye-sparing surgery or eye-sparing removal of the tumor. If we do exenteration, obviously it's unsighted. That's the main complication of the surgery. But if we do eye-sparing tumor removal, then the patient severe a lot because of ocular pain and double vision and ocular surface irritation. Sometimes they cannot use the eye, and we just shut down the please. We do permanent orthorrhaphy. Another paper that was published by Alon Tiusano, he found that with sophisticated statistical analysis that we can predict the response of patient to vismodegib by the initial response. If we see a 20% reduction in tumor size at 3 months, then we can predict 80% response to the medication. If we check the patient after 6 months and we see about 70% reduction, then we can predict 95% final tumor reduction. So we actually know if there is no tumor reduction at 3 months, we can stop the medication. Not all patients respond to vismodegib, and we cannot delineate which patient will respond and others will not. And this is the last paper that we submitted yesterday. It's about squamous cell carcinoma, the first patient I described. There was no treatment for squamous carcinoma, advanced periocular squamous cell carcinoma, and this tends to do perineural invasion through the supraorbital or supratrochlear nerves. And for these patients, sometimes we did exenteration, and when it got into the cavernous sinus, even surgery would not be helpful. I think Beta Ismaili was the first one to describe either MEK inhibitor or PD-1 inhibitor for the locally advanced squamous cell carcinoma with good success. She published it in the OPRS about 15 years ago. And cemiplimab, which is a relatively newer PD-1 inhibitor, now is used for this kind of disease. And we described the largest series with 13 patients that received the cemiplimab for 5 months. Most of them had very mild adverse effect. This is in contrast to the vismodegib for BCC. We had complete response in 54% and partial response in 2% and stable disease in 8%, which gives about 80% almost cure or stable disease, a relatively high number, because these patients either would have gone exoneration or they were inoperable and they would just suffer. So with these newer medications today, and when I first read the papers about the Vismo, it was almost like magic, because you cannot believe that the solid tumor around the eye that you used to operate and remove, do complete excision, is actually curable by a medication. And this is actually the biggest revolution that I see in oculoplastic, the medical oncology treatment, along with radiation and adjuvant chemotherapy. But nowadays, we hardly do exenteration, only for mucor, but we hardly do exenteration for this tumor, even for melanoma. We do give them a medical treatment. And this is, for me, it's just seeing the evolution of oculoplastic in the past 20 years. It's really good for us and for the patient, obviously. And I really wish to thank you again for inviting me and to give this talk and to these interesting topics that you gave. Thank you.
Thanks, Guy. It was amazing. I wonder, and I have a question regarding what you said about the cases that you presented. Something that we struggle here, and I wish to hear your thoughts about it. Frozen section versus MOS versus rapid paraffin, usually when melanoma is on stake. But whenever you have a suspected lesion that is deep in the orbit, would you go to frozen section? Would you go to MOS? Are there any options? Are both options available at your center, or what is your preferences? That's one thing. And another thing, if you can just emphasize a bit more and speak a bit more about the posterior lamella. Basically, how do you reconstruct the posterior lamella? You spoke about the nasal harvesting, and you spoke about taking tusses from the contralateral eye. So if you can just emphasize a bit more. You said that tusses is not well tolerated in the upper eyelid. We usually use tusses from the contralateral eye. We don't use tusses, we don't harvest tusses or other thing for the posterior lamella from the nasal perichondrium. or any other harvesting. So these two things.
For the first question, for nodular basal cell carcinoma, which is solid tumor, frozen section I think is the best option. You don't have to do frozen section if you see one lesion or one nodule that you can excise with 2 or 3 millimeters margins. There was a paper published about nodular BCC that even 0.2 millimeters of histology-free margin, it's not clinical, obviously it's histology, is sufficient to tumor removal without recurrence, is equivalent to 3 millimeter clear margin. The major problem is morphiform or squamous cell carcinoma. We tend to do more epagetoid spread. So this is the way frozen section is mandatory. And we use frozen section. It's not exactly most micrographic surgery. We don't like most around the eye because I think most is more designed to the facial area where you can actually take large defects without any local morbidity. For the eyelids, it would be more complex. It's really difficult to do frozen section when you have orbital fat involvement. But we do take frozen section for basal cell and squamous cell carcinoma. For melanoma, obviously, frozen is not an option, so we do rapid paraffin. Rapid paraffin can be done within 24 to 48 hours. At our hospital, it took us 1 week, no, nearly 1 week, but it doesn't matter if you just close the upper eyelid, then there's no problem. And regarding upper eyelid reconstruction, I think taking contralateral tarsus is an excellent option, but that's the only option that the eye would tolerate without contact lens. Okay. We don't do cutler beard. I know people do cutler beard a lot with good aesthetic result, but not good functional result because the patient have to use contact lens for life. Doing pericordial graft from the nasal septum, it's only done for the lower eyelid. You can use either that because you don't need to use buccal membrane mucosa. It's a composite graft and both lamella survive. You can take ear cartilage when you do a cutler beard or for the lower eyelid, but the ear cartilage you have to cover with either conjunctiva or buccal membrane graft. I personally never use amniotic membrane. I don't think amniotic membrane is as strong as powerful in ocular surface reconstruction. I know Professor Salomon uses a lot and many people use that. But I think for severe defects, even for ocular cicatricial pemphigoid, when you need to reconstruct the fornices, I preferably use buccal membrane graft. I think it's a much more powerful graft, even though it's unsightly. But I think taking free tarsal graft from the upper eyelid, the other upper eyelid would be a good option if you don't have a complete defect of the upper eyelid. If you have a complete defect, which is not very common, obviously, then doing the Mustarda switch flap is an option that should be considered. And there was a large webinar by the AZOPers about 1 month ago talking about eyelid reconstruction, and nobody actually mentioned this Mustarda flap. And when I consulted many of my colleagues, both in the States and Australia, only one knew of this flap, and I think it's something that we can use. It's written in old books.
Excellent. I second you about the treatment that we can offer today patients, the medical treatment that we can offer them. At least in our hands, I think that we see slightly more adverse effects. So a lot of patients in our institute stop the medication because they can't tolerate it, both young patients and elderly patients. So it's interesting to see that you, I think, have a series with more tolerable patients. I don't know, patients here, at least in our hands, are really reluctant to continue with it because of side effects.
You're talking about the Arivage, right? Not about the PD-1 inhibitors.
Yeah, correct.
Yeah, you're right. Yeah, I think about 1/3 of patients would not tolerate, even though they would know they would suffer and have a severe surgery. But some patients you can persuade to take it, other you cannot. But I agree about at least 1/3 of patients would not take the Arivage because of the severe side effects.
Yeah, excellent. Thanks. I don't see any other questions in the chat. So, Zvi, do you have any comment, or can we continue to your presentation?
Yes, just one comment. I was wondering if theoretically you can use for the upper eyelid a periostal flap like we use for the lower eyelid, or do you think it might be not stable enough for the upper lid?
No, I think it would be stable. I use mostly periostal flap for the lower canthal reconstruction for the lower eyelid. It's easier, and also it's also reattaches the lower eyelid to the right position. So when I have a large defect in the lower eyelid, either central or temporal, So I preserve the tarsus in the corneal surface. Now, if I have a central defect, I remove the temporal tarsus to the central cornea, and then I do a periostal flap to the lateral canthal area alone. So you can also do a periostal flap to the lower upper eyelid, but you don't have enough to reconstruct the posterior lamella of the upper eyelid. I would not do it for the upper eyelid, only for the lateral canthal area, where there's no contact with the cornea, only with the lateral surface. But it's an excellent flap. It's readily available and it provides excellent blood supply. It's not as sighty, but it's really, really a good option. It saves you second stage. It's a one-stage procedure. But do you have any experience with the periostal flap to the upper eyelid?
No, mainly for the lower, and also
for the lower,
mainly for the canthal area.
Yeah, for the canthal area, it's the best. But even for central defects, you can mobilize the temporal tarsus, bring it to the center, and then create a new defect temporally, and that reconstruct with the periostal flap, which is almost the way we try to avoid use flap when we can, but it's not always possible.
Mm. All right.
Okay. Excellent. Thanks a lot, Guy. We'll continue for the second presentation by Zvi Gur from our department. An interesting case of tumor in the lacrimal sac, pediatric tumor in the lacrimal sac. Zvi, please.
No, it's not. Just a second. I have some technical issues here. Okay, can you see my screen?
Yes.
Okay, so I will be presenting a solitary fibrous tumor of the lacrimal sac in a pediatric patient. So the case begins with a 16-year-old female who presents with right-sided epiphora for 5 years, along with progressively enlarging mass at the medial canthal area. This is her picture, and you can notice at the front picture that there is a mass at the canthal area. The mass causes a hyperglobus and causes lid distortion that is almost obstructing her visual axis. On palpation, it felt very solid and not mobile. And here on the lateral view, you can see some bluish discoloration under the skin. This raised the suspicious for vascular lesion. So we performed imaging to see the extent of the lesion, and also because of the proximity to the base, skull base, we need to rule out any CNS connections to the lesions. So this is a MRI showing mass that is arising from the lacrimal sac, a T1 MRI. The mass size was about 2.5 to 3.5 centimeters, and you can appreciate it, the size, by comparing the mass size to the globe itself. The mass appeared to be slightly hypo to iso intense and did not demonstrate diffusion restriction on imaging. Now, due to the mass size and anterior location, which was preseptal, we decided to continue with the transcutaneous approach for lesion removal. So I'll show you the video of the surgical case, a brief video. So the surgery starts with a modified Lynch incision, and after the incision, the basic principle of excising this mass is to perform only blunt dissection. So you start with blunt tip scissors and you move to malleable. Everything is done bluntly, not to avoid, not to damage the capsule itself. Now at this point, when we looked at the imaging, the lesion itself looked very, very similar to the imaging. So we thought it's almost complete excision with negative margins. So here we cut the connective tissue and we close the skin with a Prolene suture. And this is the picture after the surgery. You can see the bilobe, the mass has appeared almost in complete symmetry to the MRI. However, in histology, we got answer that the solitary fibrous tumor that was transected with positive margin. On the left picture, you can see the STAT6 staining, which is very typical for a solitary fibrous tumor. And here on the right picture, you can see the pattern of solitary fibrous tumor, which is actually patternless pattern. Also, the lesion was positive for CD34, which is also very typical for solitary fibrous tumor. And when we did molecular testing on the DNA, we found that there was a fusion gene of NAB2 and STAT6, which is also very typical for solitary fibrous tumor. This is a picture of the patient post-operative at week 4. You can see that the mass is gone, and the scar is, we can say that it's relatively acceptable. However, owing the transected margin, and so we did another MRI. And here you can see the leftover of the lesion, which has appeared very anterior, also preseptal, above the area of the medial canthal tendon. So this spot, owing the age of the patient and the potential for malignant transformation, we decided to do second surgery. However, this time we did upper lid crease incision very medially. We took a negative margin, and the lesion was excised completely. And this is a picture of the patient after 3 months. You see that the scar is even looked much better, and the globe are in good symmetry in position and level. So solitary fibrous tumor is actually known as solitary tumor of the pleura. It is mainly a benign tumor. However, it is benign. It can sometimes behave aggressively, can compress off the globe, and in more serious cases, it can even compress the optic nerve. It can occur in any part of the body, but also in the orbit, and composed of spindle-shaped cells. The histopathology, we see a moderate cellularity with a lot of bands of collagen and cells that contains very little cytoplasm. And then here the pattern is a patternless pattern. When we're doing a CT imaging for solitary fibrous tumor, so in the compared to the gray matter, the lesion itself is slightly hyper attenuated compared to the gray matter. And in early phase, you can see that there is very homogeneous, this lesion. And in late phase, you can see rapid washout of the contrast material. And this is important note because compared to cavernous hemangioma, for instance, it's showing a late washout of contrast material. And the presentation can be very similar of both lesions. In terms of immunohistochemistry and genetics, so it is positive for CD34 and BCL2. It's very sensitive, the CD34, almost 100% of the cases. However, in malignant cases, in updated literature, the CD34 may be negative. At the genetic level, fusion of the genes NAB2 and STAT6 are located at chromosome 12. Now, hemangioperoxatoma and solitary fibrous tumor are very similar. They both have patternless pattern, and they have this staghorn configuration of blood vessels. They both are stained positive for CD34 and appear in very similar cases. Now, in updated literature, now people are starting to talk that it's even the same family of neoplastic sarcomas. However, we need to know that hemangioperoxatoma have more tendency to become malignant, about 30% compared to 10 or to 12% in solitary fibrous tumor. Now, there are some features that can suggest malignant or, I guess, regressive behavior of the tumor. So clinically, usually after incomplete resection or radiation therapy, on CT scan, usually we will see bony changes, hypercellularity, and necrosis. On the molecular level, Ki67, which is a nuclear protein, which is more than 10%, high mitotic figures, positivity of P53, and it's a question mark about CD34, the presence of the absence of this marker for malignant variations. Now, the management of incomplete resection of solitary fibrous tumor is composes a big dilemma, especially in cases where there is the location of the lesion is hard to reach. For instance, deep in the orbit or close to the apex. Now, this is a suggested algorithm for incomplete resection. So if the histology benign, the lesion itself, so we're doing serial imaging and excision if possible. However, if the histology is showing malignant feature, like I showed you in the previous slide, so if the positive the margins are positive, so we need to target it locally, either by trying to do another surgery for excision or trying to make radiation therapy. If the negative if the margins are negative, we can do serial imaging and follow-up. So in summary, solitary fibrous tumor is a benign tumor. However, it may have aggressive behavior. Malignant transformation is possible, and it's stain positive for CD34 and BCL2. And incomplete resection should be managed very carefully. This is all, and thank you.
Thanks, Tzvi. I have a question to you. Maybe Guy, maybe you can answer as well. Something regarding the imaging in these cases. It's definitely not a straightforward case. You spoke about the diffuse restriction initially, the initial assessment of the case. Can you just Tzvi, let us understand how does this advance your management of the case when you the diffuse restriction or the imaging? Regarding
yes, the diffuse restriction usually indicates, most of the time, it indicates hypercellularity of the lesion. So now in pediatric population, if you have a lesion in the orbit which is hypercellular, we need to think about first of rhabdomyosarcoma. However, in some cases, rarely, also dermoid can show diffuse restriction. But certainly in pediatric patients that show diffuse restriction, you must think about rhabdo. Of course, you need to see the clinical course because the rhabdo is advancing more aggressively than just a dermoid in the orbit. But in general, it shows the cellularity of the lesion, the diffuse restriction. In this case, there was no diffuse restriction.
Guy, any comments?
Yeah, the same answer. Also, a pass in the orbit, like abscess can show a diffusion restriction. When we see a restriction diffusion, normally it's a malignant tumor, unless the case is a dermoid and pass, and then we do a biopsy. But I think this is an excellent case. SFT you have to remove, although it's a benign tumor, you have to remove that because of the possible malignant transformation, the rapid growth. And imaging is, as you nicely said, do you see a rapid, it's very brisk contrast enhancement and then rapid washout because it's very highly vascular. And if you cannot remove the tumor as a whole, as you beautifully did, then it tends to bleed a lot, especially if it's deep in the orbit, so you have to do really nice exposure, and you did really an amazing surgery. We had 2 cases, one like that in the orbit in a pediatric patient, which was difficult to remove. It was done by a neurosurgical approach. And another one, a lady with multiple breast carcinoma. She's very young, 50-year-old with multiple breast metastases. And she had SFT inside the lacrimal sac. So we did almost an en-bloc resection of the sac, but she recurred. And when she recurred after 2 years, we did do re-excision of the tumor. Because you have to remove that, unlike hemangioma or any other benign tumors. SFT, even though it's benign, it has to be removed, and removed as a whole, and it's a beautiful surgery, really. Really nice case.
What do you think about reconstruction of the lacrimal system after SFT in the lacrimal sac? Do you wait? Textbook answer says 5 years, but do you really wait?
Even for basal cell, it says 5 years, but I wait 2 years. For pediatric cases, if you remove the upper system, then Nachum Rosen actually published that it doesn't do a Lester-Jones tube in younger patients of 15-year-old. I don't know what's your experience. Do you do a Lester-Jones tube for younger patients?
Actually, I don't have experience. I didn't saw a case with a pediatric with upper lacrimal system obstruction so far.
But for them, I would wait until at least 2 years, and if there's no recurrence after 2 years, then I would consider to reconstruct. Because you remove it beautifully, you removed almost like a benign tumor. It was really nice. It's not easy to remove, as you said.
Excellent. I don't think we have any more questions, so I think we can wrap it up. Thank you very much.
Thank you.
Thank you, Tzvi.